Hello, my name is Richard Vautry. I'm the chair of the BMA's GP committee and the lead negotiator for the contract changes which I'm about to describe, which relate to the 2020-21 contract in general practice for England. This presentation will outline the contract package that the GPC England has negotiated for GPs in England this year. This is part of the 5-year package and builds on last year's agreement. We have, however, secured some significant improvements and additional funding. It's also worth saying, again from the outset, that this contract is based on the GMS-PMS contract. It isn't separate from it. It therefore builds on and secures the independent contractor model, rather than, as some previously feared, moving to a new type of integrated model. This is investing in the national GMS contract, and by doing so links across to the PMS contract too. This provides opportunity not only for the investment to be secure, but also for GPs to lead the change, for you to lead and develop the services in your practice and PCN, placing you in an influential position. The agreement will bring significant changes, not just for the investment and workforce to the PCN, but also to your individual practices. These changes are just as much about investing at practice level as well as PCN level, and both as part of the GMS contract. We now know that through the hard work of many GPs, the vast majority of practices are part of a PCN. It was just a short period following our original agreement last year, but in a few months virtually all practices have got involved. But we know that we can't overburden and overwhelm PCNs with lots of expectations that we haven't got the capacity to deliver on. And we also need to spend some time educating people about what PCNs are and what they are not. They are not PCTs or PCGs that can feed the performance management beast with data. They are groups of practices that are grouped together to benefit the patients within that community. So one of the things that will be important in the coming year will be to develop the links between those other organisations working in your area, particularly the community service providers and mental health service providers. They need to be party to the network agreement, so you can be sure how they will work with your PCN and how practices can benefit from those wider workforce, such as linking with district nurses and community matrons into a multidisciplinary team, or having mental health therapists in your practices, and by doing so, starting to rebuild the primary care team, who can help shoulder the work of providing services for your patients in your practices. It's already starting to happen in some parts of the country and is making a real difference for those practices involved. What we want now is it to be formalised for the coming year for all practices. Because there are several changes which I will highlight, we're starting to formalise and simplify the process for practices to make decisions about whether they will or won't be part of the DES. Normally, the practice manager or someone working with them has to fill out all the forms and submits them on an annual basis to the CCG. We want to reduce this unnecessary bureaucracy, and looking at a longer-term contract, we're moving towards an opt-out process. There will be an assumption that you want to remain as a PCN, but this remains a voluntary scheme, and there will be an opportunity each year for practices to opt out. Once a month will be the norm, but for this first year there will be 2 months, April and May, to decide and notify the CCG and the other practices in your area. It's important to make that decision early so that the other practices that want to take part know for sure who they're going to be working with and what patients will be included, to give some certainty. It'll also assist with getting the money flowing for the PCN at the earliest opportunity. For once all practices are signed up, then the money can flow to all practices. Another important agreement is to try avoiding the scenario where we've secured national funding and commitments only for the CCG to take away the same amount of money and use it for something else, and practices are left as no better off as a result. That's not acceptable. So we've agreed with NHS England that we will insist that CCGs invest the same, if not more, in their area. If there's a scheme already working in your area that is now mirrored in the national agreement, which pays more funding within the PCN-DES, then they will need to retain that funding, especially if you've used that local funding to employ staff, such as an advanced nurse practitioner. The expectation is that funding will remain, but if it's duplicated by funding within the national contract, then it should be retained but used for something else in general practice. Local medical committees, LMCs, will have an important role in ensuring CCGs do this and increase their funding over the years, as was outlined clearly in the long-term plan. Another change we've made in response to concerns from practices over the last year is that about the practice workforce baseline, which is NHS England's way of ensuring that the new staff are truly additional, not just moved from elsewhere within the system. If a practice lost one of its baseline roles, then this would impact the funding the PCN can receive for the ARRS roles. We've secured some improved flexibilities around that, and there will now be a 3-month grace period for the practice to replace them. But crucially, they don't need to replace like for like. You now have the flexibilities to replace a clinical pharmacist with a physio or a physician's associate if you want to. CCGs will also be expected to support the recruitment of the new ARRS staff. We know that it's really difficult in many parts of the country, so we're making sure they get the support from the CCGs, not just for recruitment, but looking at other ways to fill any gaps. For instance, if you can't recruit a pharmacist or a physio, then the CCG could facilitate some rotational scheme with the local trust or the ambulance service for paramedics. So, with more support, we should be able to get the full complement of staff in place in each and every PCN. You'll know the draft service specifications came out just before Christmas, a nice Christmas present for everyone. I don't think so. That included targets, lots of workload and micromanagement. Quite rightly, there was a huge pushback from GPs, practices, PCNs, clinical directors, LMCs and lots of local and national organisations. Everyone saying the same thing, that this was not helpful to the future direction of general practice in their area. Actually, it was very helpful that everybody was saying the same thing to enable us to persuade NHS England to make radical changes and to take a very different approach. Just short of 4,000 responses enabled us to secure changes to the service specifications and get back to a position that we feel is workable with the workforce that PCNs and practices can get, not something that was unrealistic and that would discourage practice involvement. So the service specifications have been significantly reduced and are now much more in line with what practices do already or what they can reasonably do with the new workforce in place. Of the 5, we're left with 3 for this year. Anticipatory care and personalised care have been put on hold for a year, and we'll negotiate those with NHS England in the coming months, but with the same principles as for the 3 for this year. We're now left with 3 specifications: SMRs, care homes and early cancer diagnosis. And the requirements are down to just 2.5 pages, which is much reduced from what it was previously, with much reduced expectations and no targets. So no performance management, but utilising the skills of the new individuals to deliver the minimal requirements. There will be non-contractual guidance produced in the coming weeks, but that's not a must-do, it's what you may do. The first one of the specifications relates to structured medication reviews. There were previously lots of anxiety about not being able to recruit pharmacists and GPs having to do the work instead. That is not the case. It is linked to the capacity of the pharmacists in your PCN, and only some of their time will be spent doing SMRs, focusing on those patients that would benefit most from them. But that's just one element of the pharmacist's time. Much of their time will be embedded in the practice team to benefit you and your practice patients directly. On care homes, there's now no requirement for the GP to do fortnightly visits of the care homes which was in the previous drafts. So now it's much more in line with what you're probably doing already. Oversight of your patients in care homes, and when it's clinically appropriate for you to see a patient in the care home, then that's what you choose to do if it's necessary. But the multidisciplinary team will review patients in the care home, and that will include your community nursing colleagues who are now expected to be part of that team, along with the relevant PCN staff, as the PCN decides, developing appropriate levels of care planning. This should mean a reduction in the workload that practices currently experience by proactively supporting patients and reducing the need for additional visits. This is already the case where practices have in place similar home care schemes. We now want all practices to benefit from this approach. We've also secured payment for every single care home bed at £120 per bed per year for all CQC registered care homes. This will be paid on an annual basis. As the clinical work this year won't start until October, the payment will be pro rata to £60 for the coming year, but it will go up to £120 in subsequent years. As I mentioned earlier, where practices are currently receiving more than this, there is an expectation for the CCG to maintain their level of higher funding, especially if they expect you to do more in your area than the national scheme specification requires. There was also a suggestion in the draft specs that the PCN would somehow become responsible for residents out of hours, but this has now gone. There will be a dashboard of indicators developed over the year to enable some peer discussion so that you can have an idea of how many within the care home have had medication reviews or other activities taking place. But there will be no performance management of this, and this will operate in the similar way that many practices already get data from the local system about their patients and their practice and their activities. This year, there is nothing in the Impact and Investment Fund attached to these service specifications, but in future years it will grow to a significant amount of money, £300 million by 2023-24, and the intent is that about a third of that money will be linked somehow to the service specifications. It'll operate a bit like QOF, so it's not something that you have to do, but if you do it and achieve, then you will get the funding. But I'll come back to that later. The cancer specification in many ways links to the quality improvement indicator in QOF for the coming year and is much in line with what practices are already doing, looking at good practice around 2-week waits, trying to identify patients not engaged in uptake of screening services, and looking at what other practices are doing and how to adopt some of that practice in your own practice arrangements. The anticipatory care and personalised care specifications will be negotiated later this year, but they are largely about the community services teams supporting patients in the community in a more proactive way and social prescribing services for patients. Finally, the CVD and health inequalities ones will also be negotiated with GPC England in the coming year and could mirror what many areas are already looking at, such as a focus on the early identification of patients with atrial fibrillation or hypertension. The key change we've been able to secure is that we've moved from 70% reimbursement of new staff groups to 100% reimbursement for all the staff groups, including the increased range of workforce that we've secured arrangements for. That includes pharmacy technicians, health coaches and care navigators. PCNs also have an option to employ dietitians, podiatrists and occupational therapists, and there are some PCNs that are wanting to do that. But we need to be careful that they are delivering GMS and PCN services and that your local services, such as podiatry service for example, are not lost or reduced as a result of the PCN doing some of that work. Nevertheless, this is a significant step from where we were, and has led to a significant increase in funding going into the GMS contract. We've not just increased the funding and the proportion that we will be reimbursed, but we've also increased the numbers of people that we intend to recruit. One of the recent election manifesto commitments was to introduce an additional 6,000 staff into primary care, and so we've increased what was intended to be 20,000 new staff to over 26,000. And now every single one of them will be covered by our new 100% funding agreement. This is a significant boost that will help each and every practice. NHS England has also written to CCGs and PCNs to state that the current funding arrangements for this year can now move to the new 100% arrangements if there is unspent funding in the ARRS pot. So you can start to recruit staff within these groups and you'll get 100% reimbursement now. It's therefore worth getting on with recruitment of the workforce as soon as you can. We also heard from many practices and PCNs about the anxiety of this being a 5-year deal. But what about year 6 and 7? The concern was that funding would be pulled and practices would be left with a large liability and the costs of a large workforce. That's no longer an anxiety, as we've got a guarantee that the funding commitments made will continue beyond the 5-year package. It will be retained as part of the GMS envelope, so practices can plan with confidence for the future. Another thing practices said to us was, well, what if NHS England changes its mind about the services and how they are delivered, and we're left with big redundancy costs, which can be significant? We've dealt with that as well, so that all practices, if they were to withdraw from the DES, the NHS retains a commitment to recommission that DES and is committed to delivering the services, so they'll look to transfer the staff over to the other provider. It could be a community provider or a new APMS contract, but the workforce then would be tupied across to that other organisation, so reducing the risk for practices. The other crucial benefit of moving from 70% to 100% reimbursement of the ARRS staff is that 30% that you would have effectively earmarked to cover this will no longer be needed to be used for this. This funding is retained within the envelope of GMS, and so it frees up the other resources that PCNs were thinking of using to fund that 30%. Some were thinking of using the £1.50 per patient or the Investment and Impact Fund, and therefore had to achieve the targets, or others were planning to take funding from the practice's global sum. None of this is any longer necessary. The funding has been secured, and it's freed up to allow you the flexibility to invest that as you want within your practices. In addition, the £1.50 per patient is now free to use as you want to. You could add more time for your clinical director or for your practice manager involved in PCN meetings or PCN business managers' roles, or other activity that you think is necessary. It is very much practice's resource to do with as you wish. All ICSs have also been given funding for the development of PCNs and clinical directors, so it's important that LMCs and PCNs are in consultation with one another and with the ICS about using that funding appropriately. It's not an insignificant amount, but probably best used for things like organisational development and enabling these embryonic entities to become a bit more stable, utilising that additional resource appropriately. The key change with the 100% reimbursement is that it might start to catalyse new thinking about how you employ these new staff. There were lots of worries about the liabilities associated with the new staff, especially being only 70% reimbursed, but now that it's 100%, I think it changes the thinking a bit, and you might want to move away from other organisations employing your staff so that they truly feel like they are part of your practice team, and you recognise that too, and as a result you get more out of them by employing them in your practices so that they know and understand what general practice looks like and how it works and operates. This is a summary of the funding, which is an increase on what we secured last year. So this year was £110 million, which was due to go up to £257 million. So that with the additional £173 million, it now goes up to £430 million. You'll see that by the end of the 4 years, we'll have secured £1.4 billion going into the GMS contract for PCNs. That's additional funding on top of the contract value, and which was previously planned to rise by £891 million. So we've made a big step forward. So what will it mean for an average primary care network? This is a typical sized PCN with just over 40,000 patients, and the funding that they would have got in 1920. And you can see the step change for the next year. But by the end of the 4 years, you're going to have around about 21 additional people fully funded, working for and in your practices, delivering care to your patients in a way that you determine. So this means a big increase in the number of people to share the workload burden. And it's for you to determine the makeup of that staff. You may want a pharmacist working in each of your practices full time. You may want some pharmacy technicians supporting those pharmacists, and physios, with patients going firstly to them rather than the GP, so reducing your own workload burden. Paramedics or physicians associates may be with the community team, start a home visiting service not just for care homes, but maybe also for your frail elderly patients as well, reducing the burden on individuals currently doing that. It really is up to you to use this resource in whichever way you want that works for you and your patients and the needs of your practices. The new Investment and Impact Fund will be £40.5 million for this coming year, growing significantly over the next 4 years, reaching £300 million annually, a significant chunk of new money for practices to secure. As I said, this will operate similarly to QOF, but at PCN level, with the funding being received by the PCN for the member practices to use on services and workforce. This can and should be used at practice level, investing in your own practices and staff. So in this coming year, it will be a payment made at the end of the year. In future years, it will be an aspiration payment made throughout the year, with a final payment at the end of the year based on achievement of the various indicators. The indicators will be developed over time, and as I've mentioned, about a third next year will be linked to the service specifications. Crucially though, you no longer need to worry about achieving this to cover your PCN staff costs. This will now be additional money, so this will be completely game-changing and will provide significant extra resource for workforce and service provision based on how you want things to work in your area. These will be the indicators for the next year. A focus on seasonal flu, with pharmacy vaccinations contributing to the overall total, although the funding within the IIF is for PCNs and pharmacies will be funded separately. Also, a focus on learning disabilities, so not only will you get the payment of a learning disability item of service for doing the check in your practice, if you achieve a certain level across the PCN, then you will also receive this additional money as well. Another domain will relate to the number of social prescribing referrals. The QOF QI scheme this year around co-prescribing of non-steroidal anti-inflammatories and PPIs, that will be recognised through this IAF domain, and there will also be an emphasis on encouraging patients to move from MDI inhalers to dry powder inhalers as their carbon footprint is much less. Finally, there will also be a focus on low-value medicines to try and discourage the use of drugs such as coproxamol or the prescription of homeopathy or other medications that have limited or no value. For those practices that do sign up to the DES, there are some significant benefits for each member to recognise. Not only benefits from 100% funding for all the new staff, but you'll benefit from the workload removal and reduction from your current practice. These are not staff doing a lot of separate work to what you and your practice staff are doing. You need to see them as an extension and integral members of your existing workforce and they will be sharing the practice workload because of that. There's also going to be an expectation that evening and weekend appointments, particularly those on the current extended access £6 per patient scheme, should really be seen as an extension of your existing services in terms of additional hours. So the intention is that these evening and weekend appointments will be used for routine activities such as appointments for a smear or an immunisation for a child or a health check or a diabetes check. They will benefit both school-age children and working-age adults that can't get an appointment during the day. Not only does it benefit the patient, but it benefits the practice too, as you can move some of those appointments to the evening or weekend. This uses the resource better, reducing your workload, but also giving benefit to the patient at the same time. You'll also have access to the £1.50 per patient, the IIF monies, and you'll retain the £1.76 per patient for network participation that's in core funding linked to your global sum. So taken all together, this is a significant resource, both financially and in terms of the new workforce, which should start to reduce your workload burden quite significantly. We all recognise that there are major issues around GP recruitment and retention, and we need to do more about that. One of the ways that we've done this is not only through securing additional funding, but by focusing on different groups of GPs. Firstly, partners. We've seen in the last few years the number of partners decline year on year, with increasing risks and workload. At my instigation, the Secretary of State for Health and Social Care initiated the partnership review, which concluded that the partnership model is something that is beneficial and should be invested in. So, as a result of that, we've secured this new scheme, which should start to re-energise the partnership way of working. So, for every new partner, which is wider than just GPs, so includes nurses, clinical pharmacists and others, they will receive £20,000 over probably a 5-year period. We've yet to agree exactly the arrangements, and we'll inform you as soon as we have done. The intent is that this would be a loan, so that they would repay a portion of it if they left before the end of that period. But if they remain, they will get to keep the full amount. As I've said, we're working on the exact details, including tax and pension implications at the moment. The payment will be prorated, based on the salaried contract measurement of a full-time GP being 37.5 hours. In addition, we've heard concerns from new partners and new GPs that they might not have the skills and training to be a partner, particularly around business management or leadership skills. So we've secured £3,000 of investment for each and every new partner to spend on those sorts of training needs. There are a small group of doctors who have left general practice but want to return with the support through the induction and refresher scheme. We've identified some funding to support childcare costs for this scheme. So if they have children under the age of 11, they'll get £2,000 per year per child to support them returning into the workforce. We also want to support locum GPs to a greater extent, particularly around CPD. So those who are willing to engage with a PCN or group of PCNs in a particular area will be entitled to a session a month of CPD, and that scheme will be developed by the Sessional GP Committee here at the BMA around those arrangements. We also want to increase the amount of time that GP trainees spend in general practice, rather than in secondary care roles that might not have any bearing on general practice itself. They really need to be spending as much time as possible getting the necessary skills and experience in general practice settings. So we've secured an extension to the proportion of time spent in general practice from the current 18 months to 24 months over the 3-year training scheme. More time with GP trainers and really getting more confidence about being a GP. Not only that, but we're increasing the number of GP training places in England from 3,500 to 4,000. So, taken together in terms of the number and greater proportion of time, if you're a training practice, you'll see far more trainees in your practice in the coming years. In those areas where there is a real problem in recruiting GPs, the targeted enhanced recruitment scheme, which has been a real success, will be expanded. So from the current 276 places, it'll go up to 500 in 2021 and then to 800 in total. So again, a new emphasis to encourage GPs to choose a particular part of the country and then want to stay there for the long term. We also recognise that many younger GPs, once they finish training, may not have the full confidence to really get into their practice, and they want to spend more time with support from others. So there will be an opportunity for all trainees to become part of the new fellowship scheme. This will provide them with an additional session a week of CPD and link them with an experienced GP. We're also going to try and attract more experienced GPs into a mentorship scheme so that they can mentor newer GPs and provide them with the benefit of their knowledge and wisdom. So we'll be developing a mentoring scheme as well along this basis. QOF has been something that has changed last year and is in evolution following the QOF review, and we're looking at each and every domain to try and ensure we are delivering the best services to patients and looking at the best evidence. This year we've looked at and updated asthma, COPD and heart failure domains, but we've also included a new indicator, which is the percentage of patients with pre-diabetes who have an annual HbA1c check, and this is a new indicator that we've secured additional funding for. So that's £10 million additional into QOF, and so the number of QOF points will increase as a result. We've also taken away the CVD indicator, which focused on risk scoring. That'll be removed, and those points will be allocated to this new hyperglycemia indicator with the additional money together, so we'll now be totalling 18 points. We have made some changes to asthma with a focus on improving the diagnosis. This is prospective, so relevant to new diagnoses made after the 1st of April. We should expect that most areas will want to refer into a properly commissioned service, either a community-based spirometry service or a hospital asthma clinic for children. It's not an expectation that every practice should or even could do this themselves. We've made it clear that we expect an increase in referrals to enable that diagnostics process to take place properly, and then going forward we can make sure the patient gets appropriate treatment. There's also some more clarity around what happens as part of an annual review, particularly in providing a care plan on an annual basis, and some modifications around the smoking indicator. Similar to asthma, for COPD there is going to be greater clarity around the diagnosis, again prospectively from 1st of April, and again we would expect more referrals to be made for this diagnosis to happen. With the heart failure indicators, we've simply split the previous indicator, and so now there are separate indicators focusing on the treatment with an ARB or ACE inhibitor and another for beta blocker treatment of heart failure. A new indicator will also formalise an annual review process for patients with heart failure, but these are patients that you're going to be seeing anyway, so it's also about making sure you code those interactions appropriately when you make a formal assessment. The QI modules will change each year, so the ones we've done this year will be replaced by the early cancer diagnosis module, and again linked to the service specification, and trying to encourage good practice around 2-week waits or engagement in screening. And also a focus on care for patients with learning disabilities. So not only will practices be paid for this through QOF, you'll also get paid for the medicals done and for the achievement under the IIF. So 3 funding streams supporting this important area of work. The QOF QI domains remain the same, so 74 points in value, and again the requirement is simple. Engage in the 2 meetings in your PCN, learn from one another as part of that peer review process, and apply that learning in your practice. We've made some really quite radical changes to the vaccinations and immunisation schemes, which have become quite a smorgasbord of different funding arrangements over time, and also some perverse incentives with cliff edge payment arrangements, with some practices losing quite large sums of money because of the immunisation choices made by just a small number of patients or their guardians or parents. We have invested new money into the scheme, so as a result of these changes we think most practices will benefit. It will be a 2-year process, as it's quite complicated to move systems. So in the first year, this will apply to MMR, and in the second year will apply to all other childhood immunisations and vaccinations. The first thing to say is that all the funding in global sum that supports the current additional service has been retained. We will be clarifying the call and recall arrangements that are variable across the country, but in terms of what practices already do, there should really be no new expectations that would cause any great concern. On top of that, there will be an item of service payment for every childhood vaccination, for MMR in the first year and the rest the year after. So how will it work? Well, if you are a practice that gets less than 50% coverage of MMR vaccinations, and I don't think there are any practices in that situation, then you wouldn't get any of the £10 and 6p for the item of service payment. If you get between 50% and 80% coverage, then you will get a proportion of that £10 and 6p. If you get above 80% coverage, then you'll get the full £10 and 6p for each and every vaccination given. So if you have 100 eligible patients in your practice and you've given MMR injections to 82 of them, you will get 82 times £10 and 6p. If you give it to 49 patients, you won't get anything other than the money that's retained within global sum. Most practices are up at the 90% level, but there are some areas that have really struggled where some populations don't see the benefit of vaccination, so we want to provide support to them. In very limited circumstances, where it's a very difficult task to get patients immunised, there may be an opportunity to retain the full payment even if you only get less than 80% coverage. If there are some good reasons for that, and you can demonstrate that and the efforts that you've gone to try and achieve higher rates of achievement. From 2021, we're going to remove the 70% and 90% targets for childhood immunisations, which have been unhelpful funding cliff edges for so many practices, where one patient makes the difference between you getting or not getting significant sums of money if you are at the 69% or 89% level. That will no longer be the case from 2021. It's likely that QOF will be modified in 2021 so that the current influenza targets in QOF might change to childhood vaccination targets. So they will be graded with upper and lower thresholds as with the rest of QOF, so it will support a graded improvement. Again, like QOF, the vaccine immunisations payments will be an aspiration payment and then a final payment based on the actual achievement. But ultimately, as we've put new investment in, all practices should benefit, and hopefully will enable every practice to go beyond their current levels of achievement, which will be beneficial to everyone concerned. We've also made some important changes for other areas of our contract, and I'm going to go over those now. We've been able to secure important changes, particularly the introduction of a postnatal health check, with additional funding to support it. This will enable every practice to invite new mothers from 6 weeks onwards, giving them the opportunity to sit down with a GP for a check that is dedicated to them. This should be separate from the baby check, and is providing dedicated time to new mothers and looking after them in a more proactive way. As a result of this and the childhood immunisations additional service changes, we're going to remove both of these additional services. Again, this is to reduce the bureaucracy and complexity of the contract. As virtually every practice are offering these services anyway, this shouldn't be a problem. We're going to make some changes to patient registration arrangements to formalise what virtually every practice is already doing, keeping their records up to date and checking patients are still registered. As we have seen some practices become very large, there's now the occasional situation where a patient is removed from a practice and the CCG can't allocate them to another practice because they only fall within the boundary of that one big practice. So what we've agreed is that the CCG can allocate the patient to another practice as an out-of-area patient. This should be very rarely necessary. Similarly, we've agreed some changes around termination of contract, so where CQC removes their registration and the practice has to close, at the moment there is no simple mechanism within the contract to terminate the contract. Again, this is exceptional, and if it ever happens, LMCs should certainly be involved. Finally, at long last, we have agreed the premises cost directions. They are with the lawyers and will be written up and released very soon. So that should give confidence to some practices to move forward in their developments. But that doesn't solve the lack of funding that's necessary for premises development, and we're pushing government very strongly to ensure that they invest in general practice, not just in building new hospitals, not least to accommodate the 26,000 people and increased number of GP trainees who will all need space to work. So we need the investment to flow, and we need the government to make that a reality. We're also focusing on reducing bureaucracy. The Minister is very keen to tackle a whole host of bureaucratic processes that create an administrative burden for practices. This will be a two-pronged approach. Firstly, within government itself, where there are many departments that ask GPs and practices to do something, and in many instances they really don't need to do that or shouldn't be asked to do that. This applies to the DWP, Home Office, Department of Justice, Department of Health and Social Care and other departments as well. And we expect to see measures brought forward to reduce unnecessary work asked of GPs and practices. NHS England will also be looking at what is within its scope of influence, so coming back to some work we did a few years ago around inappropriate transfer of work from hospitals, fit notes and prescriptions, and not sending them to GPs when they could be done by others first. Similarly, national training standards, and maybe looking at appraisal and revalidation elements to try and reduce the burden on individual GPs. We've agreed that we'll encourage practices to refer patients to appropriate weight management services. Most practices are already doing this, but there's a recognition of the need for more services locally to be able to refer these patients to. We'll also be working with NHS England on their NHS People's Plan, which is a pan-NHS initiative and will have an element related to general practice within it. And this is about trying to encourage good employment practice for all of our staff, our nurses, practice managers, receptionists, admin teams and all the many other people who help and support us day after day. And we've also secured agreement that CCGs will be expected to produce an annual funding report, which they will have to share with the LMC, to enable the LMC to track the investment and to ensure that funding is increasing and avoiding the situation where funding is given with one hand and taken away locally with the other. There's also the digital elements that we agreed last year. So the digitalisation of Lloyd George records is now underway with pilots which will be rolled out shortly. This isn't something practices should do themselves. It will be done on the national programme and will ultimately free up space in the practice, as well as creating a single electronic record. From April this year, all practices will be expected to offer patients online access to prospective data. Practices should also be offering online access to the entire record, but in exceptional circumstances where it's really too difficult to provide historic data because of redaction or third-party information issues, then you won't have to do this. Patients can, though, use subject access requests to get full access to their records. Also, from April this year, practices will need to have an up-to-date online presence and information for patients electronically, in the same way as you have information in your practice leaflet. I'd now like to turn to issues relating to pay and pensions. The DDRB process is behind again this year. This will apply for salary GPs, and that announcement will therefore need to be retrospective to enable an uplift to their pay once the announcement is made. This will probably be used also by practices to benchmark practice staff pay. Anyone with NHS earnings of £150,000 or more, as was agreed last year, will be included in a national declaration arrangement. This is similar to what already happens for senior health service managers, for trust medical directors and for local authority bodies. We'll give more information about the process as it develops. This relates purely to the superannuable pay that you receive from the NHS. We've also made an important agreement around enhanced shared parental leave. This will apply to salary GPs in the first instance, and again we'll provide more detail on how this would be introduced in the year once we have agreed the changes. This already applies for junior doctors in hospitals. We've also recognised that there is a big gender pay gap for salaried GPs, bigger than for partners, so we need to take ownership of the issue and do something about it. So we'll be working with the government and NHS England on that in the coming year. and we're still pushing strongly on our real concerns about pensions. We've asked the Chancellor to take this very seriously in the coming budget, as it really is having a large impact on a lot of doctors and GPs particularly. That is not a tenable situation. This year NHS England and Government worked on the in-year fix, which will apply for the annual allowance tax charge, so you'll need to use the scheme pays for that. We're still waiting for the exact process from NHS England, but they have made a clear commitment that this will happen. Your accountant should be able to give you advice if this is a possibility, and if so, you really should sign up to the scheme pays scheme. But we need a long-term fix for pensions rather than this in-year sticking plaster arrangement. So, in summary, the overall funding changes for the coming year at practice level look something like this. Global sum will increase by 4%. QOF will go up by 3.8%. That includes the additional funding for new indicators and also the usual population increases. And the out-of-hours adjustments are shown there as well. Here are some figures around the various changes we've made this year, which is in addition to what we'd already agreed last year. The contract price value has increased by £20 million. The DES rises by £166 million, so a significant increase to that, which includes the ARRS. By 2023-24, the total ARRS pot will be over £1.4 billion, so a large amount of new funding that we will need to make the most of. And the average practice income will go up to 1.3 million by 2023-24. So we're investing in both practice and PCN level. But remember that you can utilise the workforce going in and funded at PCN level to support you at practice level too. And remember too, that because of the deal we struck last year around indemnity, that cost and the above inflation in-year rises that were happening each and every year no longer is your responsibility. It's now for government to fund that instead. You can see here the implication for practices and their practice baseline and the different elements that contributes to. Of course, as this is part of the GMS contract, many of the funding streams, such as the IIF, that go to the PCN can, with your agreement, go to the practice for what practices want to spend it on. You'll see that there are no access targets in this agreement. We pushed back strongly against all of those suggestions that were being made last year. We warned the government not to make the same mistakes as previous ones have done, and so far they have listened to us. It's possible, though, that there may be additional money coming in here linked to access, but that will only happen once it's been negotiated with GPC England. Finally, this graphic shows the different elements at PCN level, practice level and individual GP level that will all contribute to the investment in general practice this year. But we can't forget that the funding going into GMS is just part of the equation. The other significant chunk of new funding goes to community services, and they are part of the new workforce to work with us at PCN level to help deliver services to our patients. We need additional funding for premises, which I've already mentioned and which we are continuing to lobby government for. There's also the funding for digital services, and we need to tackle the pensions issues, as I've mentioned earlier. And crucially, we need to ensure the local funding provided by CCGs is retained and increased, and that CCGs are held to account to do this. These are major changes that has brought in the biggest boost in funding for general practice for over a decade, enabling us to employ more workforce to reduce our personal workload burden. The changes deliver more flexibility and more investment at practice level. And I hope you'll agree that this provides us with an opportunity for us to really shape our services to benefit not just us or our practices, but particularly our patients.